Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Rifampicin, also known as rifampin, it is a semi-synthetic derivative of rifamycin. We all know rifampin, rifabutin and rifapentin. All these three comes under rifamycin class of antibiotics, from where this rifamycin is produced by fermentation by the bacterium A. mycolatopsis rifamycinica. Coming to its pharmacology, it is available in capsule, syrup and IV injection formulations. It should be taken on an empty stomach. Why? Food and antacids reduces the absorption. So we have to give 1 hour prior to food or antacids or 2 hours later. Here antacids and proton pump inhibitors are entirely different. Antacids works against the already present acid, whereas proton pump inhibitors inhibits the acid production. So only for antacids rifampicin absorption will be reduced, as it is highly lipophilic, crosses blood-brain barrier, crosses placenta and found in breast milk also. It reaches peak in 2 to 4 hours, same T-half of 2 to 4 hours. But this T-half when given daily, as rifampicin is an enzyme inducer, it induces its own metabolism called autoinduction, ultimately leading to reduction in T-half. Both bioavailability and plasma protein bound percentages are almost same, 70% to 80% respectively. It is metabolized in liver and excreted mainly via liver only, bile and then ultimately through feces. As it is eliminated very less in urine, so in mild renal disease patients, no need to adjust the dosages, it is safe. Whereas in liver abnormalities, we have to adjust the dosages and have to be cautious. It gives orange-red discoloration to all the body secretions, feces and urine also. Coming to mechanism of action, it binds to beta subunit of bacterial DNA-dependent RNA polymerase, thus directly inhibiting mRNA synthesis. Ultimately, no proteins will be formed, which leads to death of the cell, that is bactericidal action. This effect is concentration dependent, which means if we give rifampicin in low dosages, it may just have a bacteriostatic effect. So it is given at standard high dosages. Coming to its mechanism of resistance, because of missense mutations in RPOB gene which encodes this beta subunit, this structure of the beta subunit will be changed. Now our drug rifampicin can't find and bind to the subunit. In addition, when given as a monotherapy, there is high chances of spontaneous resistance. So it is used rarely as a monotherapy except for prophylaxis. Only in prophylaxis, this solo performance of rifampicin is entertained. Rest of all, it is given along with some other drugs. Why? To avoid resistance. Coming to its uses, it is used for treating intracellular pathogens, as it can achieve high intracellular concentrations. Only two FDA approved uses are tuberculosis and meningitis, T and M. Here in meningococcal disease, it is used only for carriers, not for active disease. Not meningitis, meningococcal disease. Coming to its off-label uses, prophylaxis. I already told you, in only prophylaxis we will give monotherapy, and in meningococcal carriers also we will give monotherapy. Prophylaxis of meningococcus, H. influenzae and leprosy, both leprosy prophylaxis and in treatment as well. Leishmaniasis and aspergillosis. In mechanism of action, I told it is a bactericidal. Here I have wrote a protozoa and a fungi. Only for theoretical purpose, we have to remember these two. Practically, rifampicin is not used for these diseases. If used also, it may be just a synergistic effect on the particular drugs which acts against them, but not a direct action over these two diseases. And then rhinoscleroma, brucellosis. Brucellosis is transmitted via unpasteurized milk, and handling infected cows. Chlamydia, tularemia. T for tularemia, T for ticks. It is transmitted via ticks, and handling infected rabbits. So it is also called as rabbit's fever. It is a bioterrorism agent A caused by Francisella tularensis, an obligate intracellular bacteria. Next, Bartonella has two species, Hensley and Quintana, causing bacillary angiomatosis. Angio means blood vessels. It is a proliferative neovascular disease, mostly affecting the skin. If it affects liver also, it is called peliosis hepatis. How it is transmitted? It is transmitted via fleas and infected cats via its bite or scratch. Hence, it is also called as cat scratch disease. Why I am telling about these two diseases deviating from the main topic is, whatever the word we come across, we have to learn at least 4 points about that to write in exam, something relevant. Then we can predict any movie story and can fill the pages if some examiners sees only the number of pages filled, or some examiners may see at least some relevant points. By either ways, at any cost, we have to pass the exam. Next, gonorrhea, methicillin sensitive staph aureus. Here in off-label uses, T and M is for tularemia, methicillin sensitive staph aureus. In FDA approved uses, T and M is for tuberculosis and meningococcal carriers. Pruritus associated with primary biliary cirrhosis. This rifampicin will reduce the circulating pruritogen bile acids. Hence, it is used in cholestatic pruritus. Here, if you observe all these diseases, most of the bacteria are obligate intracellular, like M. leprae, Francisella tularensis, Bartonella brucellosis, and Chlamydia. Rest of all are facultative intracellular pathogens, justifying the usage of rifampicin as it accumulates well intracellularly. Coming to adverse effects, GI, epigastric distress, nausea, vomiting, diarrhea. Enzyme induction leads to reduced adrenaline and thyroid hormones, altered vitamin D metabolism, leading to reduction in vitamin D, calcium, and phosphorus. If vitamin D and calcium is reduced, to compensate the loss, secondary hyperparathyroidism develops. Porphyria exacerbation, particularly acute intermittent porphyria, because of enzyme induction. Delta amino levulinic acid synthetase enzyme induction. CNS side effects, as it will cross blood-brain barrier, causing ataxia, headache, drowsiness, dizziness, inability to concentrate, and fatigue. Main adverse effect is hepatotoxicity. It may be asymptomatic LFT derangement like elevation in transaminases, or symptomatic hepatotoxicity in particularly with patients of predisposing factors like concomitant use of hepatotoxins, isoniazid, and alcohol, HIV co-infection, history of liver disease, pregnancy, and postpartum patients. Here, all these predisposing factors will become relative contraindication, obviously, and absolute contraindication will become hypersensitivity for any drug. So I am not going to write again contraindications separately, and to avoid this content overload, I am not writing it. You have to derive from adverse effects, both investigations and monitoring, and then contraindications. In pregnancy, particularly in third trimester, it will lead to postpartum hemorrhage and hemorrhagic disease of newborn because of reduction in vitamin K dependent clotting factors. Hence, we have to supplement vitamin K to pregnant ladies and vitamin K injections immediately after birth to newborn. Immunological effects. When used intermittently and in high dosages, rifampicin has immunogenic properties. That means it leads to the formation of rifampin-dependent antibodies, which may lead to cutaneous syndrome, GI syndrome, influenza-like syndrome. Here, main thing is flu-like syndrome. and it may also lead to more severe thrombocytopenia, hemolytic anemia, respiratory insufficiency, acute renal failure. Hence, we have to monitor CBC, platelets, and LFTs also, along with mainly RF. Along with mainly LFT, we have to monitor RFTs also. Increased risk of deep vein thrombosis. Why? It may reduce the anticoagulants. Mainly rifampicin as an enzyme inducer, it reduces serum levels of multiple drugs like antiepileptics, phenytoin, lamotrigine, antiarrhythmics like amiodarone, quinidine, disopyramide, anticoagulants like warfarin, benzodiazepines like triazolam, midazolam, bronchodilators like theophylline, calcineurin inhibitors, corticosteroids like methylprednisolone dexa, calcium channel blockers like nifedipine, verapamil, and dapsone, hormonal contraceptives. Main drug interaction here is hormonal contraceptives. The only antibiotic which leads to OCP failure is rifampin. Oral hypoglycemic agents, tolbutamide, glipizide, glyburide, HMG-CoA reductase inhibitor, Simva, Lova, and atorvastatin. In lepromatous leprosy and rhinoscleroma, both off-label users of rifampicin has a classical feature called foamy macrophages. What is the difference? In lepromatous leprosy, they are called lepra cells or Virchow cells, which contain acid-fast bacilli called M. leprae. As this bacilli is obligate intracellular, which likes both macrophages and squam cells. Whereas in rhinoscleroma, it is called a Mikulicz cell, which contains gram-negative bacilli called Klebsiella rhinoscleromatis. It is not an obligate intracellular bacilli, but our macrophage engulfs it and, unable to eliminate, leads to chronic granulomatous disease called rhinoscleroma. We will be studying in leprosy. We will see foamy macrophages, lepra cells vaguely, but in specific, it is only seen in lepromatous leprosy because of huge number of bacilli forming clumps inside the macrophage, which leads to a foamy macrophage called lepra cell or Virchow cell. Remember the channel name. Don't forget to like, share, and subscribe. Thank you. Hasta la vista. До свидания.